Hi everyone. In this lecture, we are going to focus on death and dying. And this chapter discusses the basic social, personal, ethical, legal, and medical perspectives on death. As surgical technologists, it's our responsibility to remain compassionate and empathetic, as we've spoke about before. And that's includes ourselves, our team, the patient, and the family. Now, a lot of times we won't be interacting with the family unless we're in some kind of non-traditional capacity. However, it's important for us to realize that there are facility protocols and the importance to know what those protocols are in an effort to ensure dignity, order, and professionalism. So all facilities are going to have a uh, detailed guidelines of this process that happens within the facility. So first, before we talk about the different models, let's just define the end of life. Now, from the medical perspective, the end of life is a period when death is expected. So this could be days, it could be weeks, it could be months, but death is imminent. And there isn't anything else that we can do to prolong this individual's life or save this individual. And so therefore, death becomes unavoidable. Now let's talk about what brain death means. The diagnosis of brain death is used when the brain ceases to function without certain life support measures in place, like we're breathing for them, all right? So like respirations and heartbeat. In the United States, brain death means real death, and there's no other distinction that we use for legal and or medical purposes. So the cause of death, who determines what that is? Well, that's the International Classification of Diseases that is set forth by the Centers for Disease Control, the CDC. So the CDC has these extensive guidelines on how to process from a legal perspective the death of an individual. So that's going to include registering the cause of death on the death certificate. And cause of death can influence the family and the community's response to the death, right? I mean, we hear things on the news all the time. If somebody passed away from natural causes and they're 100 years old, that doesn't really shock us much, although we can still remain empathetic. But if somebody died suddenly from a motor vehicle accident, or they took their own life, or there was a shooting or something like that, like those things that are sudden and tragic and unexpected, those have the tendency to affect us more, right? Death due to terminal illness is by definition usually expected by the family and the community. Again, if there's some kind of one situation that comes to mind is with Alex Trebek, that used to host Jeopardy. We knew for a really long time that he had pancreatic cancer, and he fought and fought and fought. And when the end came, it wasn't a huge surprise. All right, we were expecting that to be the end result. And then lastly, chronic illness. Again, with chronic illnesses, death is more expected and it's not as a surprise. So we have more time to prepare ourselves, right? So let's jump into a discussion about some different models. Now, the main one that the book talks about was designed by a Swiss psychiatrist, and her name is Elizabeth Kubler-Ross. And it's really interesting, and we'll talk about the different stages of grief that she defined, but I was watching a video about her near the end of her life, and she um, was saying how she's traveled all over the world and talked to people in their last moments, hours, days, weeks, and then to be going through the process herself when she knew the end was near for herself. And I just thought that was very interesting how she described these things that she was feeling. And her model has received a lot of criticism because it's very it kind of puts things into a box. And critics of the Kubler-Ross model say, wait, people can be put into a box. There's our experiences and our culture and our beliefs and our worldview, and all of these things go into how we process death, right? Whether it's our own or somebody else's. And she kind of spoke to that, how she vacillated between one stage and another stage, and skipped around and kind of came back to another one. And I thought that was really interesting. So let's talk about what those 5 stages are. The first one is denial, right? Denial. The patient denies that they're dying. Nope, this can't happen to me. Nope, it's not going to happen. This is a defensive protective mechanism that we have that's built in, right? We deny things that our brain doesn't want to process yet or isn't ready to process yet. And then the next stage that follows denial is anger. And anger could be at the person themselves that is facing the death, or that person could project that onto their healthcare workers, their friends, their family, anybody like that, right? They could express that anger. They could be very demanding. They could refuse treatment. They could refuse nutrition. This is an attempt, a last-ditch effort, if you will, to gain control over the person's environment, all right, through anger. The next stage that the Kubler-Ross model defines is bargaining, right? Bargaining is that inner attempt with the greater something in the universe, right? Depending on what the individual believes in. It may be, well, I'm going to pray really hard and, God is going to fix me, or whatever the case may be, all right? There's a bargaining process that goes on in an attempt to bargain with the entity that life will be prolonged, all right, and death will be postponed. The next stage is depression. And, the thought originally was that, depression is just part of the dying process, but now they've realized there can be some clinical undertones to it, and so oftentimes they do treat that as a clinical situation and not just, poo-poo it away, like, oh, that's just what happens. And then lastly, hopefully, after this process that the individual is going through, they arrive at acceptance. Some people never get there, right? Whether it's the person that's dying or the family or the friend, okay? Sometimes they don't get there. I can remember my uncle, on my mom's side, her baby brother, was addicted to methamphetamines for most of his life and was in and out of jail because of it. And the last time he was in jail was for about 2 years. And while he was there, he found Jesus. And he cleaned up his act. And he turned a new leaf and he got sober. And about 2 years after that, he was diagnosed with biliary cancer. And I can remember visiting him and him saying, maybe this is my punishment. Maybe, if I would have lived a better life, if I wouldn't have made the choices that I made, maybe I could see my kids grow up and graduate. He was young. He was in his 50s. And so at near the end, he finally said, I'm ready to go home, right? But not all people get there. Okay, and that is where critics like William McDougall and Charles Core come in, and they say, hey, you can't put people's process of, how they metabolize this idea that they're coming to the end of their life, you can't put that in a box with a pretty bow. People are individuals, right? Our experiences shape us. Our culture shapes us. Our beliefs, our level of education. There's a whole bunch of things that go into that. And so, William McDougall, he says that, the dying process needs to be integrated with existing life experiences. And he advocated for maintaining a sense of awareness in relationship to one's environment. And then Charles Core, he was a big critic of Kubler-Ross's model as well, and advocated for the uniqueness of individuals during the death and dying process. Okay, so again, Kubler-Ross, we talked about denial, anger, bargaining, depression, and acceptance. So how can we as individuals and surgical techs relate or explain a situation of death and dying? And how might we comfort a patient or a loved one? Think about that for a second. So what are some things that we can do, right? What is our role? Well, as surgical techs, our role is going to be to focus on what the patient is currently experiencing, right? We're going to be with this patient for a short snippet of time, right? And, our job is going to focus on those physiological needs, right? Also, a focus on emotional comfort as well. It's important, again, the things we talked about in the last lecture about the care of the patient, that we just focus on them, actively listen to them, show respect to them and their family. And then lastly, we don't want to write checks that we can't cash. All right. In other words, we don't want to promise that, oh, they're going to be fine, that we're going to fix you. All right. We can promise that we're going to do everything in our power to take the best care of them. We can promise that. Okay. But we can't promise that we're going to fix them. All right. And then, like I said before, in the traditional role, this isn't on our shoulders, the responsibility of dealing with the family. But in the case that we do, we want to validate their emotions, right? We don't want to minimize how they're feeling. And then we also want to have an awareness of what resources the facility offers so that we can connect them to those resources to help them get the support that they need. And then offer acknowledgement for their loss, right? I'm really sorry. And then facilitate communication, like I said, between family and other healthcare individuals. Usually we're not going to be answering their questions. We need to know who can, right? That's the most important thing that we can do. If we are not engaged in surgery, then having a knowledge of those things and being able to connect them with the resources that they need, very important. Okay, moving on, we're going to talk about ethical considerations. So the first, is called self-determination, right? And self-determination is the right, your right, my right, the patient's right to make decisions about how you live and how you die. Okay? This is called advanced care planning, right? And that communicates our personal needs and wishes regarding the death and dying process, how we die. We have a right to say how we die, all right? A right to choose. But this is a very ethical topic, right? This is very touchy because that brings in the idea of assisted suicide, right? Remember Kevorkian? So while we have a right to choose our death, how we die, refuse treatment, all right, not treating a dying patient is very different from helping them die. Okay, so if the patient says, I don't want food anymore, I don't want anything, I just want to be comfortable until I pass away. Okay, that's one thing. But then assisted suicide is another thing. I want you to take this medication and inject it into me so that I die. Right? That is a different thing altogether. And there are some states that allow that, and those states include Oregon, California, Washington, Vermont, and Montana. All right. So let's talk a little bit about advanced directives, advanced healthcare directives. Now, this is a document, it's a legal and binding document, and this has the individual's wishes regarding healthcare. And there are two big buzzwords, or, well, I guess there's do not intubate and there's do not resuscitate. So DNI and DNR are two of the big ones. And the patient signs the DNR, and then that goes in their medical chart, okay? And so every single time that the patient comes to the OR, that DNR needs to be verified and re-verified. The patient could have changed their wishes, all right? So it always needs to be verified. We don't do a lot of digging in the chart, but just so that you know that the DNR would be there. Now let's talk about palliative care, all right? Sorry, I forgot to kind of click through my slides. Advanced directives, DNR, DNI, DNAR. So conflicts in palliative care. Well, when we are sane in our membrane, we need to devise a living will. I'm going to suggest if you don't have one, that you get one. Have a living will, all right? This takes a lot of pressure off of your family. If something were to happen, God forbid, something happens, there is a document that can speak for you, all right? They may not agree with it, but at least they know what your wishes are, and those were communicated, and they can, plan accordingly. I'm an only child. If something happens to one of my parents, I'm going to be the ones deciding what happens. Do I know what their wishes are? Not exactly. I've talked to them. It's a difficult conversation. It's hard to have that conversation, Mom, Dad. Do you have something that says how you want to die? Nobody wants to talk about that. I don't want to think about being without my parents. But when the time comes, I feel like the only thing that's going to bring me a little bit of peace in that situation is knowing that I carried out their last wishes. And so I'm going to urge you to have a living will if you don't already have one. The living will is going to specify the exact nature of the palliative care that the person wants, that you want, that I want, that Mom and Dad wants. Okay. Also wanted to talk about how spiritual and religious concepts kind of bleed into this, if you will. We all have our own beliefs regarding the meaning of life and the meaning of death. What happened before we were born? what happens after we die? Nobody's really come back and told us any of that information. And, so that's where, spiritualism and religion and culture really lend themselves to how an individual is going to perceive death, or what their last wishes might be, right? Understanding those things is something I've mentioned before. It's a concept called cultural competence, right? Cultural competence comes with experience and with continuing education, pushing forward to always educate ourselves, to keep an open mind, to not judge, to have respect for others' beliefs, to agree, to disagree. All right, the determination of death. So the determination of death in surgery, all right, anesthesia care provider is going to call that. Okay, they're going to verify that brain death has occurred. And to determine that, there may be some specific medical assessments. Heart's not beating, patient's not breathing. Okay, there is absence of cranial reflexes. They might look at the EEG. They might, in extreme circumstances, ask for a CT scan, okay, and get a CT scan. All right. If a patient dies intraoperatively, for the most part, it's a coroner's case. The book talks about how, after the patient dies, things are going to be carried out kind of in a routine manner. But we'll get into a coroner's case in a second. But that is, typically what happens in the operating room is what we call a coroner's case. All right. So, again, there is assessment criteria for determining death, and we talked about that. In the operating room, our role is going to be a lot similar to what it always is, and we're just going to take directions from the team, and we're going to follow the facility's protocol as far as that goes. Okay, let's talk about a little bit about postmortem care. So postmortem care, the goal of that is to prepare the body for viewing for the family and to assist in handling procedures that are going to be carried out by the morgue and the mortuary. So postmortem care is different for every facility. They have their own guidelines, and we also have to take into consideration state and federal laws as well. Okay. Now, natural changes that occur in the body, what we can expect to see. Well, immediately after death, the temperature of the body is going to drop. So the body is going to start to cool, and all of those muscles that held in urine and feces are going to relax, right? They're going to lose their tone, and the eyes will not shut by themselves. The eyes are going to remain open. The jaw will drop down. And any pressure points where the body is resting, those areas are going to collect with fluid. We call this livor mortis. Livor mortis. And then, after about 15 minutes, the body is going to start to stiffen. Okay, and this is called rigor mortis, and this process peaks at about 8 to 10 hours and then starts to reverse itself. Okay, so rigor mortis begins at the head and it progresses to the feet, and then the body relaxes in the opposite way from the feet up to the head. Okay. Let's talk a little bit about coroner's cases. So like I said, coroner's cases, they're typically if somebody dies in the operating room, it's a coroner's case. Some circumstances, that could mean that it's a coroner's case. Again, death in the operating room or emergency room, an unwitnessed death. You come in and you find that the patient is deceased, right? Death after admission from another facility. Maybe they were at one hospital and they stabilized them and they flew them to another hospital and they died there, okay? A death in which criminal activity is suspected, right? Maybe the deceased was a perpetrator or a victim. If it was a suicide, that becomes a coroner's case as well. Death of an incarcerated individual. And there could be other criteria as well. These are just some of them. And that's, varies from state to state. But all implanted devices are going to be left in place. The IV is not going to be taken out. The tube's not going to be taken out. I did have an experience not too long after I started scrubbing. Was actually just taking call. I had just been hired, maybe scrubbing for about 3 months. I was tagging along with my preceptor. We got called in for ruptured AAA. That was my first death on the table. After about 6 hours of surgery, she expired. And that became a coroner's case. So we basically took our instruments off the field. We pushed our table and our Mayo stand back away from the field. We removed the drapes and we just left the patient there and we waited for the coroner to come. There wasn't really much else that we could do. I don't even remember them asking us any questions. All right, it was, for all intents and purposes, natural causes. She bled out. All right. So, organ recovery, organ procurement. As surge techs, we can work on a procurement team, which is pretty amazing that this service provides quality of life to a lot of people. And so as far as permission for recovery, here in the state of Arizona, we can choose to be an organ donor, and that goes on our driver's license. We can do that when we start driving. Parents can overturn that up to the child's age of 18. And then some states have a required request law where the physician has to ask the family's permission to recover organs from the deceased. As far as protocols, there is a lot of communication and data collection that goes into this to build a registry. And these services are available 24 hours a day. We like to perform the recovery. It used to be called harvesting. They don't call it that anymore, procurement or recovery, as soon as possible after death. And I did get to scrub in on an organ procurement. There was 1 million people in the room. There were 2 surgeons, 2 residents, an anesthesiologist. The patient had a brain aneurysm. She was 40 years old, and she was an organ donor. So we did it in the middle of the night when there's low census in the hospital, and that was quite an experience. I always thought that I might be interested in working for the procurement team, but it's just so strange that at the end of the case, you suck out all the patient's blood and body fluids. They turn the anesthesia machine off. We put the patient, a toe tag on the patient, put them in a bag, and took them to the morgue. And that it conflicts with, working in the operating room. We save people, and we are saving people by doing organ recovery. Don't get me wrong, but I discovered that wasn't for me. But I did get a really cool letter from the organ recovery organization, and it said the different parts that we procured and how they went to help different individuals. So that was pretty cool. There are 2 different types of donor cadavers, heart beating or non-heart beating. So heart beating, their heart is beating, all right, and their organs are being perfused. all right, and they're getting blood to them. Usually the patient's on cardiopulmonary support, and that is what keeps the blood pumping to those tissues that have to remain viable, via tissue blood perfusion. And then there is the non-heart beating cadaver, which is that individual that doesn't have, a heart beating. And we can procure tissues like bone, heart valve, skin, blood vessels, cornea, tendons. Have to have a heart beating cadaver to take tissues like the lungs and the heart and the kidneys and the liver and those kinds of things. All right. Again, this is becomes an ethical situation, right? Many cultures and faiths forbid organ removal, and if there's no decision that has been made, then that decision falls to the family, which is a difficult position. All right, we're coming into the home stretch here, just talking about us, right? The healthcare workers. How we respond to death in the operating room is going to vary. It's going to vary, all right, depending on our experiences, our beliefs, our culture, all right, those kinds of things. I call that our perspectacles, right? We all wear these perspectacles, and they're the lenses that we see life through, okay? And we all wear different ones, right? And so some factors that can influence us, again, our experience, the support that we have in the environment, our beliefs and values, our knowledge about the process of death, our own emotional well-being, okay? We may experience some of those stages of grief from the Kubler-Ross Model, right? Facilities may have a debriefing process where we can meet with our team and we can talk about what happened and how are we feeling, all right? It's okay to discuss the details. It's okay to acknowledge our feelings. I'm feeling angry, or I'm feeling sad, or you know what? I'm pressing this down, I can't deal with it, or I don't know how to deal with it. Okay, it's okay to share those things. And then sometimes just a nice distraction, right? That's okay too. Well, we don't want to stuff our feelings down and avoid them forever, but sometimes a distraction is nice for us. And then lastly, and most importantly, and I cannot say this enough, is your own self-care. Take care of yourself, okay? You can't take care of your patients if you don't take care of yourself first, okay? So self-care. Is it exercise? Get the rest you need. Drink water. Eat nutritional foods, okay? Do your hobby, all right? Don't neglect yourself, because this job is physical, emotional, mental, all right? It impacts you as a human. And because of that, we need to make sure that we're in tip-top shape so that we can be that advocate that we want to be for our patient and for our surgical team. All right, well, we did it. We got through this very difficult topic. Thank you for hanging in there with me. I really appreciate it. And I look forward to discussing further any questions that you may have.